So yesterday's patient of adherent leukoma with posterior subcapsular cataract, he agreed for the cataract surgery. So we are performing the cataract surgery under local anesthesia. Now I am making the main port with 2.75 knife. Very slowly and gently enter into the anterior chamber. And now I am putting the viscoelastic to deepen the anterior chamber, and also with the gel cannula I just check the iris connection with the cornea at the place of adherent leukoma. And now with the help of a dialer I am sweeping the dialer through anterior chamber to disconnect the iris from the cornea. You can see now the iris is detached from the cornea. A lot of pigment released. You should remove all this pigment at the end of the surgery. And now you can see I have swept the dialer, and there is no more connection. And now with the help of a simcoe cannula I am removing all the gel from the anterior chamber along with the pigment. So we have separated the iris from the cornea, and now we will stain the anterior chamber, the anterior capsule with blue dye to perform capsulorhexis. Now capsulorhexis is a very important step of phacoemulsification, and in such cases where there is obstructed view due to large adherent leukoma corneal opacity, you need to perform as large and smooth and regular capsulorhexis. If there are cuts in the capsulorhexis, then you will not be able to perform phacoemulsification. So make sure that your capsulorhexis is intact. It doesn't get radial. It doesn't go beyond your visualization and your control. Like here, the anterior chamber gets shallowed, so I came out, I put viscoelastic to reform the anterior chamber. Now again with the help of cystotome I continued the capsulorhexis, and there is a blind spot while performing capsulorhexis, but I successfully completed capsulorhexis. At the end of the surgery I will also show you capsulorhexis margin. And now another important step in such cases is hydrodissection. You should perform as much hydrodissection as possible because there is not a very good view. So make sure that the lens, the nucleus is completely separated from the capsule. And now after putting viscoelastic we are starting the phacoemulsification. You can see that it's a very soft case, as in a previous video I have told you that it's a posterior subcapsular cataract. So make sure you should remind yourself that you are performing phacoemulsification of a soft cataract. So remember all the points of soft cataract surgery. Now I have eaten the nucleus in the center, and now the nucleus as well as cortical sheets are present at the periphery. So now I am feeling difficulty to remove those peripheral nuclear pieces. I try to engage the pieces, but feeling difficulty, and I don't want to induce a PCR. So I came out of the. Here I have engaged some pieces. Now it's a little bit a dangerous technique, but you can see that I have taken most of the nucleus in the center. So when in order to dislodge these peripheral cortical and nuclear sheets, I am again performing the hydrodissection. That's another technique. When you have not properly divided the nucleus and you emulsify the center of the nucleus, then in order to engage and suck the peripheral sheets, you just put the hydro cannula under the anterior capsule edge and again put the gush of fluid, and it separates these peripheral cortical sheets, and then it become easy for you to aspirate those sheets. If they are thin sheets, you can use simcoe cannula. If they are thicker sheets like these one, you can perform phacoemulsification, because now in the second step of the phacoemulsification, you can see that now phaco is easily engaging these sheets, and so that's another trick which I have told you, that if the nucleus become lollipop, then you can come out and do further hydrodissection, and then you will be able to remove those. Now I am removing the air bubbles because there were too much air bubbles that were hindering the already compromised view. And I have also dislodged, you can see the cortical sheets. In a soft cataract, you will have to encounter a lot of cortical sheets, and this case is not only soft, but also there is a corneal opacity, and pupil is also obstructed on one side. Now you can see the with the help of phaco irrigation aspiration mode, now I am removing these thin sheets. Now almost you can see that the most of the sheets are removed. And now with the help of a simcoe cannula, now that's the large posterior sheets that has been dislodged with the simcoe cannula from the main port. So one of my friend who wanted how to use simcoe cannula, well, that's how you use a simcoe cannula. You sweep through under the anterior capsule edge and then suck with the 5 cc syringe, but you severely suck. You can see that once the anterior chamber become collapsed, so you should not vigorously suck the syringe of the irrigation aspiration cannula. There is a lot of cortical matter in this soft case, but you have to remove all those sheets, because if these sheets remain next day, they will just look like after cataract or posterior capsular opacification, and you will have no justification of such a long and careful surgery. So spend extra few minutes but remove each and every cortical sheets. And now from the side port I am removing those sheets. So in this video you can also learn how to use a simcoe cannula, especially for superior cortical sheets. The ideal port is the side port, and for the inferior cortical sheets you can use the main port. But you must be an expert while doing IA from the main port, because when you are using the main port there are more chances of anterior chamber collapse and you may rupture the posterior capsule. So almost more than double time was taken by the removal of these soft cortical sheets as compared to other steps of phacoemulsification. But surgery is going well. In such cases you need to be very gentle. And now I have implanted the foldable IOL in the bag. Leading hepatic is in the bag and the following hepatic I am pushing it with the help of a dialer. Now lens is in the bag, and in this view I am not seeing any cortical sheets, but if there are some hidden sheets in the bag, in the deep recesses, when you put the IOL they also gets dislodged. And like here you can see, especially in the area where there is a corneal opacity, you should. And now you have got the support of IOL. Now you can boldly go and look how large cortical sheet we have just removed. So still there is cortical matter, especially under the opacified corneal area. So all these sheets were now removed, and now that's the look. And you can also appreciate the capsule rhexis margin in the view inferiorly. So lens is in the bag. So uneventful phaco of this case. Thank you very much.